I will not go into great details, which I like to go through with ST1s usually, but I will do a bit of teaching on each case. The format will remain the same. We have got 4 candidates. Time, I am not sure where, maybe we'll go beyond time, and this is sort of an experiment from my side. So let's see. Candidate 1, are you with us?
Yes, sir.
Okay, just 1 second. Somebody is asking. Just give me time to do some. I have to make a few co-hosts. Just 1 second. Right. So, if you can ask me for the mouse, please. I'll give you the history then.
Okay. How I use your mouse, you mean?
Can somebody tell the candidate how to ask for mouse? And for future, anybody who wants to become a candidate, you should ask your colleagues beforehand. There are a few things involved.
Okay. Okay.
Any of the candidates, if you are co-host, unmute and tell candidate 1 how to ask mouse.
If you click on at the top of the screen, there's an option called View Options.
Okay.
Can you see that?
Yes.
And if you click down on that list, and it will tell you to request remote control.
Okay, I did this and then request.
Yeah, so approved your request. Here you are. Now, this patient is a 42-year-old. He has got pain epigastrium with hematemesis. Some blood came out in the vomit. Severe pain epigastrium. He also has got history of intermittent hematuria. So that's the history. Over to you. So we have done a non-enhanced and an arterial phase because of the history of hematemesis. And I'm showing you the arterial phase. Over to you.
Okay. And I'm presenting case of CT abdomen, arterial phase. I want to have a look on the study before commenting. Oh,
just 1 second. Let me reset it. Don't move your mouse, please. Over to you now. Scroll it. You can also hold from here, and you can scroll this bar. So hold from here, and you can scroll from here. Over to you.
Okay, thank you so much.
So, madam, can I stop
There is an aneurysm, yes.
Just 1 second. 1 second.
Yeah.
Just 1 second. This is wrong technique, what you are doing. There is
Yes.
no way that you are supposed to be so quiet in the examination. So
Okay.
it is when you start scrolling, tell the examiner what you are doing. And it
Okay.
is justified to go for, but you cannot stay quiet for as long as you were. So over to you now.
Okay. Sorry. I can see a hyper intense focal area in front of the has the same intensity as the aorta. I think this is related to one of the I want now to check which vessel is this area related to. I think it's related to the superior mesenteric artery. This area of hyperintense enhancement is surrounded by also congested mesentery and hyper dense surrounding hematoma. My diagnosis for this is a severe mesenteric artery aneurysm, and it's ruptured. One. I want now to check the signs of the hypovolemia. Signs of hypovolemia like the flattened IVC. And if there is any fluid collection in the abdomen. Okay, I feel that the IVC is seen somewhat flattened in relative to, and it's smaller than the aorta. Also,
Can I stop you there?
Yeah.
You are going to a wrong tangent. So can I stop you there?
Yes.
The patient has presented with acute hematemesis, vomiting of blood, and he has got history of chronic hematuria. Look at the kidneys, look at the duodenum. Over to you.
Oh, okay. I want to check the kidneys. I think kidneys, the cortex of the kidneys is seen intact with the normal cortico medullary differentiation. There is no focal areas of there is no focal area hypo dense area for infarction or infection. I want also to check the yes, I can see a hyper intense signal in the duodenal wall, in the duodenal lumen. Yeah.
Where is it? Point it out to me. Point it out to me. Yeah. Okay. So let me, because of time factor, let me tell you that this particular focus which you have picked up on a non-contrast scan, it did not show any high density. What is your inference then?
If it's not showing any hyper dense enhancement, if it's not showing enhancement, means this is a kind of extra vasation inside the bowel, inside the like there is leakage, blood leakage.
Leakage.
This is contrast leakage.
Okay, just 1 second. Leave the mouse for me. What do you think is this where I'm pointing out?
Yes, sir.
This thing. Can you see my mouse?
See.
What is this? Do you see this cortex? Do you see this?
Sorry, you mean there is not a mouse, there is a kind of rolled arrow. So
yeah, that is my mouse. The rolled arrow
where is
is
it?
mouse. Rolled arrow is my mouse.
Okay.
So what is
This
this
area?
structure? Yeah.
It's an aneurysm.
So in conclusion, what is your conclusion then?
So if we have here multiple aneurysms artery and seen also in the right renal.
We'll come back to the case. So polyarthritis nodosa is the diagnosis of this case. Polyarthritis nodosa is a multi-system, autoimmune type of abnormality in which there is vasculitis of small and large vessels. Small and medium-sized vessels. Key point is, actually it can involve anything, but the key point is the most common involvement is of kidney. Most common is kidney, then is mesentery and maybe liver. So GIT and kidney is what you have to. These patients will present to you with classical presentation, which I have, and this was the first this patient was diagnosed on this scan, by the way. And so basically you will find multiple aneurysms. You can find thrombosed aneurysms, you can find pseudoaneurysms which are leaking, and then you will find effects of previous, for example, in the kidneys, I will show you that there were chronic infections in this case. And so, and with that, you can see stenosis at times complete obliteration of vessels. So that's the theoretical part of it. Now, in our case, I am going to show you the DICOMs again, but on this CT scan, so non-enhanced, I'll go through this once again in DICOM format just to make a point that on axial pre-contrast T1 weighted sequence, pre-contrast CT, non-enhanced CT, there is no stone in the kidney. Otherwise, you cannot diagnose an aneurysm because you will always ask for a non-enhanced. In the duodenum, where you picked up, that active bleed, there was no high density material. Now, this is your case, and you can see that there is a pseudoaneurysm this is a pseudoaneurysm, partly leaking, mesenteric vessel. And then we have got this high density material within the duodenum, and this was the cause of the active bleed. They will ask you, what will you do? And in this era, the the gastroenterologist, they deal with it. And if the vessel is very large, they might ask IR, but they can sort of control this bleeding. Now, look carefully at the kidney. Look at this lower pole. You can see chronic infarction. Even here, you can see this infarction. And with that was this, small aneurysm, small vessel, which is dilated. Now, so this is the coronal of the same case. Another thing which I want to point out that here in the mesentery, there is a thrombosed aneurysm. I'll show you on the DICOM. So things are happening. It tells you that, you see here, this is that chronic infarction. This is that aneurysm. This is another cortical infarction, so it's a chronic condition which is going on. This is from our A to Z course, and this is what FRCR exam is about. They will show you multiple presentation or unusual presentation of the same condition. And look at this is totally different. Here, what is happening that, you can see this, low density material, low density soft tissue around the kidney, and this is subcapsular, and that is why it is causing this indentation. And these are, there is a differential. This is a very important case for the exam, what I am showing you. And
Yes.
the differential diagnosis for this is a lymphoma. Lymphomas can also present like this. But this case is this is the NGO of the case. An NGO of this case, which I'm showing you as an example. And you can see these, tens of micro, and madam, you can keep quiet, please. Uh, uh, these are micro aneurysms, which are, you can see, or bilaterally. This is from literature where, look at this low density, and this is lymphoma. Lymphomas is the differential diagnosis. This is on ultrasound. So, abnormal or unusual presentation of the same condition. So this is what it was about. Now, let me go through quickly the DICOM. Now, if you see here, just this was the non-enhanced, and on non-enhanced, just to make a point, that there was no increased density in the duodenum, so there was no food residue or anything. And then this is the kidney, just to make the point that there is no stone there. This is that pseudo aneurysm, which shows a bit of fat stranding. If I go down in the mesentery, you can see something else happening here. Now we go to the arterial phase, and on arterial phase, as you pointed out, that this is the D1, and you can see this high density. This is that active bleed. With that, this mesenteric vessel has got aneurysm and surrounding fat stranding. With that, we can, that the second, chronic aneurysm, thrombosed aneurysm. This is that chronic aneurysm which is thrombosed. And with that, we can see this chronic infarction here. You can see the cortex is gone. You can see here also the cortex is gone. There is micro aneurysm here. And the same findings we can confirm on, of course, the coronal section. This was that aneurysm number 1, aneurysm number 2, and then the aneurysm number 3, and then the active bleed, which is this one, and the chronic infarct. Okay, well done. So case 2 for you. This case is 3 years old, and he is losing visual acuity very rapidly. Over to you. Candidate 1, over to you.
Yes. I am presenting MRI brain.
Have you got the mouse control, please? Have you got the mouse?
Yes.
Yeah.
Okay. I'm presenting a case of MRI brain. I would like to check the study before commenting. I can see hyper intense signal seen. This is T2 study sequence. So I can see hyper intense signals are seen in the basal abnormal hyper intense signals are seen in the basal ganglia, affecting the thalamus and the lentiform, also lentiform nucleus. Down to the same study, I can see also hyper intense, the same foci of hyper intense signal are extending to the both temporal loops, and also to the bones bilaterally. Affection. I want also to check the other if it's there is more affection for the cerebellum. I think the cerebellum is.
Look at the orbits,
Yes.
please. Look at the orbit.
Okay. Look at the orbit. Okay. The eye globes are showing normal lens in place. I can see also here the optic nerve bilateral scene is showing is showing a mild increase in the thickness of both. They are
Well done. Well
quite
done.
expanding.
Excuse me. Well done. I'll give you another sequence. Okay. Over to you.
Okay. This is a flare sequence, coronal section. I want to have a look on the optic nerves. Oh no, I'm down. Okay, the same hyper intense signals are seen here. I want to check the optic canal and the optic nerves. So this is the last.
Yes.
Okay. I feel that I think there is a widening in the optic foramen, and there is the signal. There is abnormal hypo intense signal is seen on the optic nerve sheath. Maybe I can't.
Just 1 second. 1 second, please.
Yes, please.
What is this where I'm pointing out?
This is the optic. I think this is the will be the optic chiasm. This is the optic chiasm. I'm sorry.
Right. So, with you know, I'm scrolling for you. I'm scrolling for you. Let me ask you, what do you think is happening? Give me your diagnosis.
There is kind of a white matter. This is 3 years old, right? So there is this myelinating disease for the white matter affecting the optic chiasm and the temporal bilateral temporal lobes.
Okay, madam. Thank you very much. Thank you. Thank you.
Yes.
I'll take over. Sorry, I am rushing you because of the time factor. You're doing well.
No
Thank
problem.
you. Now, case 2. Case 2 is bilateral optic nerve glioma, and this is a case of NF1. NF1 NF1 is a absolute favorite of the exam, absolute favorite. One of the top things, if you tell me, I've got 3 hours, just teach me the top things for FRCR. I'll teach you FN and F1 as one of them. There are so many manifestations that I can take a 3-hour session on it, and they come in the exam again and again. Please remember the definition of NF1. NF1 definition is very interesting. It is in front of your eyes. If you see, there are 7 points there. And out of these 7 points, the first 4 points are not radiological points. So K-Foley spots, axillary freckling, leash nodules, first degree relative of NF1. This is all clinical. These are where the action is where radiology comes into play. If the patient has got two or more than, or a single plexiform neurofibroma, two or more than two, or a single plexiform neurofibroma, optic nerve glioma, and bone dysplasia. The bone dysplasias you should know can be bare orbit, dural ectasia, pseudoarthrosis. Now, in your Chapman, this thing I recommend highly that you should read it very carefully. Each line can be a case in the exam. Remember, I don't have time to show you everything, but during these sessions, I will show you many other examples also. Today, I'm just concentrating on one aspect of NF1, which is in the brain. But read it very carefully. NF1, this is in the second part of Chapman 590 page, and neurofibromas, and then skull, and then brain and spine, thorax, abdomen, MSK, vascular, etc., etc. And then we go to NF2, which is different than NF1. Now, this thing, there is another differential. This is from the 6th edition of Chapman, which is, hematomatous lesions. I'll come back to this point. Optic pathway glioma, intracranial. So we are talking about intracranial manifestations of NF1. First is hematomatous lesions. What is this? I will show you. Optic nerve glioma, non-optic pathway glioma, plexiform neurofibroma, and absence of dysplastic sphenoid wings, calvarial defects, dural ectasia, etc. Now, coming back to optic nerve glioma, optic nerve glioma is a very low-grade tumor. Low-grade tumors might not enhance. So remember this. And that is why they might remain undiagnosed. People say that if you compare the optic nerves, and if there is a difference of about 2 millimeters between the two, and particularly if the optic nerve is tortuous, like this one versus this one, which is normal, this is a unilateral optic nerve glioma. The examiner will show you coronal. Coronal, of course, axial is very important, but they will show you then coronal. And I'll show you the coronal in DICOM, where you have to develop your anatomy and develop your reflexes to look at the optic nerve as it passes within the orbit and then goes into the intracranial component. So quickly, I am going to show you a few cases. This is from our Basildon A to Z course, and I had to cut most of the stuff because there was too much. But if you see here a revision of the optic pathway, we have got optic nerve, then optic chiasma, and then it goes to the lateral geniculate ganglion, and then the optic radiation and the occipital cortex. Now, key point to remember is that optic nerve gliomas can go back, follow this pathway, and they can be bilateral. Key point to remember. And this is what was happening in the case which I showed you. So this is what was happening. Now, this is from literature where this is from actually American College of Radiology, and you can see, for example, I don't think so it's projecting very well, these two ones, but you can see, tortuous vessels here. The key point here is that there is a bit of enhancement here. The optic chiasma is thickened. Enhancement here means the tumor is going all the way towards the lateral geniculate ganglion next to the thalamus. But the but is, please remember that optic nerve gliomas are grade 1 tumors. They might not enhance. So this is close to what I showed you. Look at this optic nerve on a coronal versus this optic nerve, and this is thickened, and this is quite, bulky. This is the type of case which I was showing you, but this one is from ACR. And once again, you can see a bulky tumor which is in the suprasellar region. That is why in the differential diagnosis in your book, supratentorial tumors in childhood and optic nerve glioma is one of them. Here, in this slide, in this case, I want to teach you the significance and the viva questions which can be asked, and the viva questions which can be asked regarding hematoma. You just heard that or read the name of hematomas. Now, these hematomas is a concept which is slightly controversial, and basically in NF1, the most common brain manifestation, 60% or something is the rate, is high signal intensity foci. These foci, previously we used to call it UBOs, unidentified bright objects. Then we started calling them unidentified neurofibromatosis objects. Then now we call them FASI, F-A-S-I, focal areas of signal intensity. Basically, the concept is some people thought that these are dysplastic nodules. Some people thought that this is myelin vacuolization. Some people call them hematomas. Key point to remember is you should know that in cases of NF1, these can happen. And these, what is the location? Practically anything can be affected. Basal ganglia, the internal capsule, the thalamus, the cerebellum, the white matter, the the brainstem, anything can be, you should know this. Second thing is a viva question will be, these lesions, they increase in size and number, particularly number till the age of 10. Key point to remember. This is a viva question. And after the age of 10, they decrease in number. They decrease in number. And for NF1 cases, we keep them under surveillance. We do 1 year follow-up scan. Some people think that these nodules, if they start increasing after the age of 10, you should be worried about malignant transformation. So it is surprising that at the age of 4, you will see so many nodules. At the age of 15, those nodules will go. They will vanish. So this is the normal behavior. And don't confuse it with anything else. Another irony is that this is the most common manifestation of NF1, as I've told you, but it is not in the definition. You know that 7 points which I told you. I think MR at that time when the definitions were made was not available or whatever. So this is focal areas of signal intensity. Now, another key point to remember is that whenever you find a case of NF1 or NF2 in the exam, what will you do next will be the viva question, and you will ask the examiner that I will scan whole of the neural axis. Key point is that you have to do with contrast of the whole spine, because there might be something sitting there, neurofibromas or meningiomas in NF2, etc., etc. So this is another case from literature where we can see close to what I was showing you. Look at this. This is optic chiasma. The optic chiasma is thickened, bilateral lesions here. And in this case, and there are a lot of fasciae also. In this case, there is enhancement. When you see enhancement in the parenchyma, means malignancy, means malignant transformation. So beware of this. So let me go through with the case which I showed you. Now, I showed you initially a T2 weighted sequence. And on this T2 weighted sequence, it is very unusual type of afference. But look at this nodule. This is that classical fasciae. It is not related with anything else. But there is a lot of edema, or lesion is going into the thalami, from there into the brainstem also. If you look at the optic nerve, not very well seen, but one can argue that there is a bit of tortuosity on this axial. So on this flare coronal, we can see it very well. You have to develop your eyes to trace it. So unfortunately, on this particular scan, the globe is not included, but these are the optic nerves. Both of them are thickened. And as we pass through the optic canal, we go to the optic chiasma, see how it is thickened. And that is why in children, supratentorial masses, optic nerve glioma is given there in your book. Suprasellar masses, and see how it goes, it follows the anatomy of the optic tract, and it goes to the optic radiation here. And I have seen one case which I could trace it all the way here. So it can go all the way there. So this is just to show you a T2. This is bilateral optic nerves. In this case, we also did the scanning of the whole of the spine. We did not pick up anything else. We also did post-contrast. So interestingly, on post-contrast, the optic nerve, there was no enhancement here. But if we trace it, now we are coming to the optic chiasma, and here, do you see this enhancement, bilateral enhancement? And this is the concept of, please remember that in brain, what happens is that a grade 1 tumor, optic nerve glioma is a grade 1 tumor, can convert to a grade 2 and then a grade 3 and, even a grade 4. So means where there is a broken blood-brain barrier, it's a higher grade. Maybe it is transforming here. So just one portion of it was enhancing, rest were not. So otherwise, for coming back to NF1, there it's a favorite. They will show you cases of, bone dysplasia, as in bare orbit, etc. They will show you MSK films, the pseudoarthrosis in the tibia, for example. They will show you dural ectasia, and the manifestation they might show you on a chest X-ray. I've got all of these cases, but today I don't have time. So, let's go to the next case.
Dr.
Candidate 1, quickly, can you describe and give me your difference?
There is well-defined osteolytic lesion is seen in the frontal bone, left frontal bone. Has a narrow zone of transition. The differential diagnosis of this lesion is eosinophilic granuloma. If it's a young child, if it's old, it will be either metastasis or multiple myeloma.
Is it young child?
It's young child, yes, I think. It's not.
Why do you say a young child? What is the evidence of a young child? So let me tell you, it's a 38-year-old. 38-year-old. 38-year-old.
38 years old.
Yeah.
Okay, so this lesion either it will be maybe a metastatic lesion.
What else can it be?
Or multiple myeloma.
Multiple myeloma in a 38-year-old.
No, there is older age.
Okay, thank you very much. Thank you. Now, let's go through this case. Now, this is an epidermoid. Now, just on one film, of course, you cannot be. So this is another, I told you that I'll show you mix of cases which can come in FRCR. And this is a differential diagnosis case, a very simple case, but I can take a viva of 30 minutes on this case if I want, because I will have a debate. What else can it be? What else can it be? You have just seen the radiological features. What were the radiological features? The radiological features were that it was lytic and there was a sclerotic margin. Sclerosis, by the way, that is a sign, and there will be lesions in which there will be no sclerosis. So this particular case I did not show you, but on CT scan, CT was not very helpful. But one thing it was helpful, there was no gross destruction. There was nothing else happening in the brain, and this is what it was. Interestingly, this is quite an old case, I think 15 years or something old in my teaching files. And 2008, yeah, the age is there. So it is quite an age, definitely 15 years old. So we'll come back to that. Why is it epidermoid? Having said that, I do understand that it might be something else, but you have to be very sure when you tell your differential diagnosis to the examiner. Please remember a key thing. If you ask me what is the key teaching point for FRCR differential diagnosis case, it is as follows. When the examiner asks you the differential diagnosis, they want you to tell the differential diagnosis on that film. This patient, this age, this clinical scenario. They do not want you to regurgitate the list from, let's say, the Chapman. You have to tell them what is relevant in that particular case. So this is the bookish differential diagnosis of skull vault lucency with sclerotic edges. There are some normal variations, and then there are developmental, which includes epidermoid. Langerhans cell histiocytosis will not be in this age group. Neoplastic, of course, you can keep it, but then if the examiner tells you it's an asymptomatic patient and it was followed up, as I've told you, for years, neoplasia cannot do that. Meningocele and cephalocele, no, it is not. It is not chronic or stimulatus for the same reasons because of the clinical history. It is not a fibrous dysplasia. So, more or less on plain film also, you are sort of confined towards epidermoid. Another case, now 15 years ago, we were not doing it, but now we understand. Please remember the word epidermoid. So this is interesting. Epidermoids can occur in the vault of the skull. We call it an epidermoid. Epidermoid can occur in the intracranial cavity. It's a very important exam case where a CP angle mass will be there and it will be low density on a CT scan, just like CSF, and you will do an MR to differentiate. And the key sequence is DWI because epidermoids show restricted diffusion. Interestingly, when the epidermoid occurs in the temporal bone, as in the middle ear cavity, particularly congenital epidermoids, we call it a cholesteatoma. So the same condition goes there. And this is the concept that a cholesteatoma will also show you restricted diffusion. And that is an exam case. I'll show you maybe next time. Cholesteatoma can characterize a lesion in the middle ear cavity. Sorry, MR can characterize with restricted diffusion. So this is another example similar to what our case was. And then now we learn the use of DWI, and we did a DWI scan, and you can see how it is restricting. So diagnosis is made. This was an epidermoid. Please remember that in your book, in your Chapman, there is another differential diagnosis, skull vault lucency without sclerotic edges. Some of the conditions, there is an overlap between both of the lists, but some of them are a black and white differentiation. And of course, age, etc., and the clinical scenario will also help you. So I'm not showing you any case, but just to highlight, skull vault lucency with sclerotic edge, which was our case, and then second one is without sclerotic edge. Okay, candidate one, well done. Thank you very much. Sorry, I had to sort of push you or rush you, but
Okay.
I have to do it for because of time factor. Well done. So yeah, thank you very much. Candidate two,
I want to ask one question.
Madam, in the end, not now.
Oh, okay, fine.
Candidate two, are you with us?
Yes.
Okay, so I'm still continuing with my commentary here. So this is the AP view of the same case, and This is the CT scan, which of course I did not show you, but I did show you the PowerPoint of this, and it looked quite benign looking. So candidate 2, over to you. Very interesting case you have got. So this is 82-year-old dementia and pain abdomen, sepsis. Rule out sepsis is the differential, is the clinical. Over to you.
Okay. So presented with a portal venous face of the abdomen and pelvis. Just going to have a quick scroll, starting from top to bottom. Okay. So a bit of fatty liver. Okay, there's a lot going on within the mesentery.
Can I stop you here? And please concentrate on this region and around this region. Can you leave the mouse for me, please? Now, I just want you to concentrate here and around this. Over to you.
Okay. So
Something happening.
I can see some sort of gas locules within this within the anterior mesentery. Just gonna have a quick scroll just to see. So if it's extraluminal with fluid tracking. So just need to just work out where it's arising from. There's a lot of fat stranding going on as well. So you can see the SMA is patent. There's a bit of high density within the bowel.
That is the stomach. Don't worry about that. So stomach and a bit of fluid, contrast there. So don't worry about that.
Okay, so there's a lot of free fluid around the mesentery with extraluminal gas. And just following this particular area.
So you're doing very well. I want you to concentrate anatomy-wise. Where are we? Where is this focus?
Okay, so if I just work my way, okay, so I'm going to just work my way from the stomach down. Okay, so that's the stomach. So I'm just going down and looking at the pylorus. Going down, I can see D1, D2. So this is the area. It looks like it's in the lesser omentum.
You mean to say lesser sac?
Lesser sac, apology.
Yeah. Okay, good. It is in the lesser sac. Please continue. Now, what is happening? Where is it going, right and left? Please tell me.
So it's not going into the retroperitoneum. So is it surrounding the pancreas? Is the question. So I'm just going to try and trace the pancreas if I can find the pancreas. It looks like gas around the pancreas with sort of low density sort of collections. This could be
diagnosis made. It is a lesser sac infective process or abscess, right? Gas locules. Yeah. I want you to tell me what are the connections of this? Where is it going, right and left?
So from okay, it's going into from the lesser sac of the stomach. Between the stomach
Okay, let me leave the mouse for me, please. Can you concentrate on, no, leave the mouse. Don't move the mouse. So if you see here, it goes, can you see that there is a bit of a ramification of this abscess? And can you concentrate on this one? Where does it go? Tell me.
So
you can take over the mouse. Yeah.
Yeah. So it's tracking all the way along here.
Very good. Well done.
Into, where is it going? I'm sorry, it's jumping.
Let me take over the mouse. I'll scroll for you. You just I've taken over the mouse. Don't worry. Now, if you just concentrate on this, I want you to see where it goes. And I am going to scroll towards one side, and now I am going to scroll backwards. And this is where it is. And I'm going to do the same thing once again. What is happening?
So is there a connection between the stomach and the transverse colon?
Is it the stomach or?
Oh, sorry, the duodenum.
Duodenum. Okay, well done. What can you do to decipher this question? Hint. Can you use contrast?
Yes.
So here you are.
Oral contrast. Yeah.
Here you are. This is about 3 days down the road. The patient actually deteriorated, but so this is what we did. We gave oral contrast and non-enhanced scan.
So just following it down from the stomach, duodenum. So here's the bowel. So just here's the connection.
Yeah. So what is your conclusion?
So this is a duodeno-colonic fistula.
Excellent. Well done. Okay, I will take over. So now this case, lesser sac abscess with duodenocolic fistula. You know, the definition of the word fistula is, it is the connection between two epithelially lined, structures. So if it blindly ends, then you call it a sinus, right? So there can be intra-abdominal sinuses also. But this one, basically, there is an abscess sitting in the lesser sac. It was retrospectively speaking, because they did endoscopy, etc., later on, and we believe that the patient was dementic, as I told you. So it must be sitting there for a while. So what happened was that there must be a duodenal perforation or duodenitis or whatever. With that abscess formation, the epicenter went into the lesser sac. It grew there, and over a period of time, which we don't know, might be weeks or months, it tracked into the mesentery, and then it fistulated into the transverse colon. So that was the unusual part of it. So a bit of anatomy of the lesser sac. We know that there is a greater sac and the lesser sac of the peritoneum. This is the lesser omentum, and behind it, this is the epiploic foramen of Winslow. And on an axial, this is a key concept for you, that this is the lesser sac. Of course, the this thing, pancreas is sitting around it, but when there will be a lesser sac abscess, it will displace the stomach anteriorly. Lesser sac abscesses can be shown on plain films. And those of you who have followed our teaching, I show it always. It's a very important film, lesser sac abscess, because you can make up your, displacement of stomach, etc., with some gas bubbles. You can make out that this is a lesser sac abscess. Now, with that, let me go back and take you through the case once again. So, this is the anatomy where we can see gas bubbles. Of course, these locules, this is the appearance of an abscess. And with that, the pancreas itself was, of course, normal, where I'm pointing it out. This is the pancreas. You can see my mouse. And then on this plain film, it's a struggle. Is there a connection here or not? You cannot be sure. But this connection is beautifully seen, with the transverse colon. So it goes all the way into the mesentery, and then it fistulates into the transverse colon. And you can see the same thing on this coronal. You can see it beautifully, that, it is going right and left, and how then it goes into the colon. And of course, these kinds of films, they do show in the exam, where, a bit of management and things like that, a bit of discussion, what can you do? And this was 3 days down the road. The patient deteriorated. You can see a bit of ascites now, but it was simple. Just give oral contrast, and it highlighted the fistula very well. Okay, and you can see the ascites has increased. The patient did not survive. That was the sad part of it. Okay, well done, candidate 2. This is your next case, and this is classical 70-mile road traffic accident, front seater rolled over. The patient has got, I think, GCS of 7 actually. So bad one. Over to you.
So presented with CT axial slices, non-contrast, trauma case. So just going to scroll from top to bottom, or bottom to top, shall I say, sorry. So scrolling, clearly page has got an ET2 bin. There's complex, obviously I'm not in typically my practice, I'll be using bone windows, but I can see that there is a left maxillary sinus fracture.
We will come back to the bone window. Let's concentrate on the brain, and then I'll show you the bone window. Over to you. Thank you.
Just scrolling up, so you can see some blood in the sphenoid sinus. So I can see there's a bit of high density around the right frontal region. It's convex in shape. Normally I would look in subdural windows for subdural hematoma. There's a bit of subgaleal hematoma on the outside as well.
Just hold on, please. I'll ask you some questions. Now, what do you think is happening here, where I'm pointing out? Can you see my mouse?
Yeah, so within the ventricle, there's a bit of hyperdensity, so interventricular hemorrhage given that.
Is it in the ventricle?
Normally in the practice I use coronals and sagittals to locate, but on this sequence it looks as if it's intraparenchymal at the just adjacent to the falx.
So what anatomically speaking, on this axial, where are we? Where are we? You're right that you will like to see a sagittal, fine, but where are we?
We're in the grey white matter sort of junction.
Okay, so I'll ask you a few more questions. What is happening here where I am this thing?
So it's intraparenchymal hemorrhage.
Right. And what do you think is happening here where I'm pointing out?
So there's a bit of air, so it's keeping a pneumocephalus.
Right. How will you confirm it?
In bone window.
Right. So, so that is fine. So let me go back to the bone window. I want you to tell me the anatomy of these fractures. Over to you.
Okay, so this is the frontal bone. You can see that there is. So there's a fracture of the left frontal sinus, completely opacified, comminuted. As I go down the lamina praeputia is also fractured. Nasal septum is deviated. There is air within the nasal sinus, ethmoid sinus, should I say, sorry. The optic nerve, I'd normally check on soft tissue window to check for the optic nerve and the orbital intraconal sort of muscles. This is a complex fracture going on within the left orbit region involving the lamina praeputia. Just looking at this, also involving the temporal bone. So I scroll, just checking the zygomatic, the zygoma as well. The zygoma seems to be minimally, check the zygoma, is minimally displaced. There's fracture of the pterygoid plates on both sides. Also the lateral axillary sinus on the right side is fractured.
Right. So conclusion, just name the injuries.
So this is most likely a Lefort 3 fracture, complex orbital fracture.
So Lefort 3 on the left side, and what is on the right side?
On the right side would be a Lefort 2.
Okay, now my final question before I go through the case, I showed you this thing. How will you name the name in your conclusion? What's happening here?
So this hyperdensity, just adjacent to the falx cerebri. Keeping with the intracranial hemorrhage.
Here you are.
Okay. So just
slightly parasagittal within the corpus callosum. How will you name it? Right, let me take over. Thank you. So this is a traumatic brain injury. What we see is we see diffuse axonal injury. We see extradural hematoma. We do see pneumocephalus, a bit of edema, etc. There are multiple fractures of the skull. There is Lefort 3 left, Lefort 1 right. So let's do a bit of quick revision. So first of all, diffuse axonal injury. Diffuse axonal injury is extremely important for the exam, and there are so many type of films which can come. Please remember the concept that this is a shearing injury. These patients will be clinically much worse off than the scan. And there are two types of diffuse axonal injury. One is hemorrhagic, second is non-hemorrhagic. Non-hemorrhagic diffuse axonal injury cannot be seen on CT scan, and it can be seen on MR, but don't go home with this idea that you will ask for an MR. At times we do MRs days down the road just for prognostic reasons and things like that. So, but they do show diffuse axonal injury in MR, particularly they will show you SWI sequence for that. Now, diffuse axonal injuries, hemorrhagic diffuse axonal injury is a classical example. It is a shearing injury. Basic concept is that various parts of the brain, they accelerate and decelerate at various velocities, and there is a shearing effect. Key point is the eye see what the mind knows. So this is a classical example where you will only pick it up if your mind tell your eye that we have to look at it. The classical location for diffuse axonal injury can be gray-white matter junction. I'll show you in this case also there was one. And then corpus callosum. So this was corpus callosum. You have to develop your eyes to pick up corpus callosum on an axial slice. And there are other, type of cases like lipoma of corpus callosum is an exam case. Then, agenesis of corpus callosum is another one. You have to develop it on your axial slice. Where is the corpus callosum? And of course, then you're justified to ask for a sagittal. Now, corpus callosum, so gray white matter junction, then is corpus callosum, then is internal capsule, then is midbrain. The midbrain injury or brainstem injury is the worst of, and these patients might come to you with Glasgow coma 4. So, and there are other sites in literature, practically anything can happen with diffuse axonal injury, but these top 4 you must remember. A concept of Lee-Fort injuries. So I'm not going to go into the intricacies of the, the facial bone anatomy, etc. The only relevant bit I want you to concentrate is pterygoid plates. Sphenoid bone has got various parts, and I'm just going to tell you about the pterygoid plates. So here, this is the pterygoid plates. Here is this is the maxilla. This is the alveolar ridge of maxilla, the upper jaw, right? So this is where the action is. And Lee-Fort was a person who experimented on cadaver skulls, and he identified lines of weaknesses, and then he defined it. Please remember, in the real world these days, nobody is bothered about Lee-Fort, and it can be a mixture, it can be it can be atypical, etc., etc. But having said that, somehow or the other, the examiners do like to ask you this. Key concept to remember is that the pterygoids are the key concept. The pterygoids will be fractured. So in this particular case, they are fractured bilaterally. Now, let's revise the pterygoid 1, pterygoid 2, and Lee-Fort 1, Lee-Fort 2, and Lee-Fort 3. So here, it cannot be shown on this diagram, but the pterygoids by definition will be fractured. That's the key point to remember. Here, the fracture line goes through it, so the alveolar ridge is only involved. And if you hold this ridge, clinically speaking, and you try to move it, you will be able to move it as the examining physician of the patient. Here, the fracture goes through just remember, don't overload yourself with information. Just remember the medial wall of the orbit, including the pterygoids. And so this structure, whole of the maxilla. In the first one, only the alveolar ridge of the maxilla was free from rest of the skeleton. Here, the whole of the maxilla becomes free. And in the third one, whole of the facial structure, facial skeleton is free from the skull. So the fracture line will involve the medial wall as well as the lateral wall of the orbit. And this is what we call craniofacial disjunction. Now, so this is a case, this is not your case, but this is from our A to Z course. You can see these pterygoid fractures and you can see multiple, both of these pterygoids are gone. The key point to remember is that here on the right side, the lateral, is the lateral wall of orbit involved or not? If it is involved, it will be Lefort 3, otherwise no. So let me go through your case. Now, this is your case. I had shown you just axial. So this is the key point to remember, that this is diffuse axonal injury. Corpus callosum is sitting here. It is very difficult. One slice superior to it and it's gone. Similarly, cases of lymphoma, etc., on an MR and heterotopia, etc., your anatomy should be up there. Now, this is gray white matter junction, small hemorrhage there. So this is another diffuse axonal. This is an extradural, fine. But of course, you picked up rest of the fractures very well, which were, the Leforts. And in this case, suppose, this is medial pterygoid, lateral pterygoid is gone. If you come to here, superiorly, the lateral wall of the orbit is also gone. Here it is intact. So maybe a Lefort 1 on the right side, Lefort 3 on the left. Of course, because of time factor, I did not show you the coronal. It is absolutely justified to ask for a coronal, and in your clinical practice, you must look at the coronal. You can never diagnose on axial, never try to diagnose it, but the examiner will ask you to check your anatomy. You can see the lateral wall of the orbit is gone. The medial wall is also gone. Of course, we had already seen that the pterygoids, here you are, this pterygoid is gone, and the other pterygoid is also fractured. So this is Lefort 3 on this side. Okay, candidate 2. This is a 17-year-old. Are you with me? Candidate 2.
Yes.
I'm showing you initially I'm showing you a T2 weighted sequence.
Yeah.
This is a 17-year-old and the patient has presented with epileptic fit. Now, I am scrolling it for you because of time factor, but I will also guide you. We are coming from down up. So, you know, the brainstem, cerebellum.
Yeah.
So I just keep looking. I will.
No problem.
Now, you see anything in the periventricular region here?
Sort of periventricular, a little bit of high signal, very mildly.
Okay. Just 1 second, because it will be very harsh for me to expect you to pick up anything there. So with this background, now I have shown you a flare sequence, and this is what we call an epilepsy protocol MR, where we do coronals. You know, multiple coronals whenever a patient comes to you with epilepsy. So over to you, 17-year-old.
So
Now you can scroll it. Now
I
you
can
can
scroll.
scroll.
Right. Okay, so flare sequence coronal. So I'm just going to just request control.
With you.
Yeah. Yep. So sorry, just bear with me 1 second. Yep.
So I have already pointed out the region of interest or area of interest. Just concentrate on that area, okay? Yeah.
So it's
Over to you.
On the flare sequence, I can see some high signal in the temporal lobes.
Temporal lobes, what do you mean? Where is it?
Actually, apologies. I mean the hippocampus, to be more precise.
Yeah, so hippocampus is fine. Don't worry about it. I want you to just concentrate on periventricular region.
Okay. So as I scroll.
Can I stop you there? I'll ask you a leading question here. Now, you see these high signal, this high, you know, don't move your mouse. There is high signal here, and you can see high signal here. Now, what do you think is happening there? Just concentrate here. I'm scrolling for you.
Okay. So periventricular high signal on the flare sequence.
Hint, look at the signal intensity and compare it with the gray matter.
So this is the same as the gray matter signal.
So what comes to your mind?
Gray matter heterotopia.
How will you confirm it?
Which sequence I use?
This is a T1.
T1.
The patient has moved a lot, so the quality is not good. This is a T2. This is a coronal T2. This is the lesion.
So would I use all sequences to compare to make sure that on all signals are same as the gray matter?
Okay, fine. Well done. Good. Now, let me take over. Now, gray matter heterotopia. the concept is that you see in a fetus, in a developing fetus, what happens is that the cells of the gray matter, they actually develop in the subependymal region, in the periventricular region, and from there is a concept of migration, and they migrate to the cortex. Now, if the migration is arrested, or some of them are arrested in periventricular region, we call it subependymal gray matter heterotopia. And it can also be arrested in the white matter, and we call it a band heterotopia. I'll show you a case. And then there is subcortical heterotopia, where you will find an abnormal appearance of the cortex. On a CT scan, it will give you a pseudomass-like picture. Gray matter, subependymal heterotopia is a very important exam case. And this should be one of your checklist. You know, if you are seeing a case, I am showing you a CT scan where you can see it very well. This is an 8-year-old, and you can see that, look at these nodules. And the key finding is that even on this CT scan, the density is equal to the gray matter. That is the key. On MR, the signal intensity will be equal to gray matter on all sequences. Do not confuse it with subependymal nodules in tuberous sclerosis, which have calcification after age of 2. But again, the signal intensity will never be equal to the gray matter. So that's the key. And I warn you that this has come in the exam, you know, on a CT scan even. Again, an example where your eyes only see what the mind knows. So this should be one of your checklist. If you are not able to pick up anything, look at this region. Now, the same case, this is the MR of the same case to make the point. You know, these nodules will be equal to the gray matter on all sequences. This is a T2. This is a T1, and you can see this gray matter versus this gray matter. This is a PD, and it is this gray matter versus this gray matter. This is a flare. It is equal on all sequences. So this is subependymal heterotopia. You know, the cortical heterotopia, which I am showing you, I don't think so this is FRCR level case. It's slightly more difficult, because the concept will be that you will be worried about what we call cortical-based low-grade glioma, etc. This is, for me, beyond FRCR. So, having said that, knowledge for your day-to-day reporting is not bad. If you had done a CT scan, believe me, you would be worried that there is a mass here. But on this MR, you can see there is, you know, subcortical heterotopia. The vessels are very prominent, but I don't want to teach you further. I just wanted to highlight that these are the 3 types. And here you can see subependymal extending to the cortex also. You see this? From here till the ventricle, it is all gray matter. So where is the white matter? It's gone. So, and the white matter is this black thing on the normal side. Band heterotopia is somewhere in between. Here what happens is that the gray matter cells, they are arrested within the white matter. So what you will find? You will find white matter, then gray matter, then white matter, then gray matter. This is white matter, gray matter, white matter, gray matter. Again, for me, this is beyond FRCR level, but good for your knowledge. But this thing I warn you is an exam case, both on CT and MR. Okay, so your case, I think we have already, so indirectly, you know, the axial was too harsh, and that is why I did not want you to, you know, you can barely see anything. Retrospectively, you can see it. So that's why I was not counting on you picking up anything. But if you see here, this is, and if you see the signal intensity, it is equal to the gray matter. If you go to the T2 weighted sequence, and the signal intensity is equal to the gray matter. If I go, you know, up and down, here you are on both sides. So this is gray matter heterotopia. Even on that T1, which is slightly degraded, this is the signal intensity. It is equal to the gray matter. Okay. Next case, please. So, how many your cases are done, isn't it? Yes. So, candidate 3, are you with us?
Yes,
Thank you.
yes, sir.
Thank you, candidate 2. Candidate 2, thank you. Candidate 3. So, what
Yes.
happened was interesting. 27-year-old, obstructive jaundice, a bit of fever, ultrasound pickup, choledocholithiasis, intrahepatic duct dilatation, and then we did an MRCP. On MRCP, it was reported that there is choledocholithiasis and intrahepatic duct dilatation. They did an ERCP. After the ERCP, they gave us a call. They said it was a very difficult ERCP. We could not succeed in dislodging anything. We are worried if we have done some damage. Can you do a CT? We did a CT. This is post-ERCP CT. Over to you.
I have requested control. Just requested.
Yeah, the mouse is with you, please.
Okay. Yeah, you can scroll. So these are the contrast enhanced images of CT abdomen in a 27-year patient post ERCP. And I can see that there are dilated intrahepatic biliary ducts. I'm just going to concentrate on the CBD now. So I can see that there are some extraluminal air foci around the pancreatic head and duodenum. The gallbladder is okay. I think there is some high density within the gallbladder, which could be calculi. So there is actually abrupt narrowing in the CBD. The proximal part of the common hepatic duct is dilated. In this region, there is abrupt narrowing of the CBD where I cannot visualize it. And then
So
the distal
when you use
CBD
the word
looks...
in this region, can you please either point out or tell me, is it mid CBD?
Yes.
Is it distal CBD?
Okay. So in this region, the CBD is dilated, the hepatic duct and the proximal CBD is dilated. And when I go down in this region, there is abrupt narrowing in the CBD. I cannot.
Is it narrowing or is it normal?
The distal CBD is normal. The intrapancreatic CBD in this region, it looks. This is normal. So there is abrupt narrowing like this. The abrupt narrowing is not normal, and the wall of the biliary duct is particularly thickened in this region as well. I think there is transaction. There could be injury to the bile duct during the ERCP.
Okay, injury to the bile duct. Just 1 second, please.
Yes.
What is this where I am pointing out?
So these are the extraluminal air foci.
Should there be air there?
Sorry?
Is it normal air?
No. They shouldn't be there. So there is, okay, I'll just, there is some bowel wall perforation as well. Okay, yeah, so the extraluminal air is tracking cranially as well.
Okay, just 1 second, please. Just 1 second. I'll give you a coronal also just to So the ear itself, let me point out the ear because then we will come back to the coronal, and I want, so there are, for example, air bubbles here, and this is an extraluminal air bubble. It is what we call retroperitoneal air, right? Retroperitoneal air bubble here.
Yes.
And so there are a few locules of air. Now, but air is just one thing. I have given you a coronal. Over to you.
Okay. These are the coronal reformatted images. Sorry. Which confirms the dilatation of the biliary tree. Okay. So I'm looking at the biliary tree now, and I can see that there is stricture in the mid CBD region with dilatation. Also, there are, I think, multiple strictures.
Did you listen to my history? You know, I told you
Yes.
that we did an MRCP, and
Yes.
on MRCP we gave the report that there is choledocholithiasis. There are stones in. Let me show you the MRCP. Just 1 second, please. Just 1 second.
Yes.
So I am intentionally showing you a T2 haste sequence instead of the MRCP series. You can see everything what I want you to pick up on this, please.
Okay. Okay, so I'm following the CBD, and I can see that there is a calculus within the mid CBD. Also, there is a calculus in the neck of the gallbladder. I think there are multiple strictures in this particular region. There is stricture at the confluence and then dilatation.
Don't worry, that's just an, because of the adjacent vessel, you are getting that finding. That is, don't worry about that.
Okay. And there is some inflammatory changes around the neck of the gallbladder. I think
so
this
give me your diagnosis. Why?
So I think this
why was the ERCP successful?
I think the calculus in the neck of the gallbladder is compressing over the CBD.
Where is the CBD? Where is the neck? You know, neck is far away from the CBD. Where is it? Where is the compression? Show me the compression.
Okay, this.
So let me give you a hint. You are close to the correct answer, but not exactly the correct answer. So you are very close. My question is more anatomical. That is another hint.
Okay. I think this is a cystic duct calculus, and then it is compressing the CBD in this region.
That's fine. So what about the gas? How will you tackle that? What will you advise? There was gas.
Okay, so there is duodenal perforation.
Duodenal perforation. So what will you advise?
Retroperitoneal gas. I think it is post-ERCP injury because it was a difficult ERCP as well.
So what will you advise?
I think it was okay. I will advise urgent surgical review because
the surgeon will not like it. They will say, "Oh, this is not our case." You know, the classical. In any case, okay, well done. Let me take over. So, so this is a this is a discussion type of a case which comes in the exam and checks your clinical knowledge also, or how will you deal with a particular case. So this was post ERCP. The scenario was that it was a, what was the age? I think I told you the age, 27 years, isn't it? Yeah, 27, obstructive jaundice. And on MRCP, we said there is choledocholithiasis. They thought it is simple as that. They went in, they said, wow, it was very difficult. We could not dislodge it, and we have come out. Now, then they did a CT scan. On that CT scan, there was retroperitoneal air, and this is a diagnosis is Marit-Seize syndrome. So what is Marit-Seize syndrome? By definition, Marit-Seize syndrome is stone in the cystic duct compressing, the common hepatic duct level, so that the distal common hepatic duct, so that there is dilatation of the common hepatic duct. And in the same definition, sometimes a stone sitting in the neck can also cause it. So more common is cystic duct, but if it is sitting in the neck, that can also cause it. This is the Marit-Seize syndrome. But the concept about pneumoretroperitoneum. So please remember that pneumoretroperitoneum has got various causes, and ERCP is a known cause. We actually don't give it much. This is the clinical point I want you to remember. We don't give it much weightage. Even a post-sphincterectomy, you will see the incidence of 0.5 to 2%. Don't overcall it. It's a conservative management. You just call it. Should we do anything? Don't worry. Correlate clinically. If the patient does not deteriorate, don't do anything. We can do a follow-up CT to document that there is no further gas. And this is what happened in this case. Now, let's go back to our case. Stop share. And this, just 1 second. So this was the CT scan. So what is happening in the CT scan? I'm not showing you the axial, but here you are. Basically, this is the distal. So this CBD is normal. This is that air bubble which we saw. And from here onward, there's something happening. Actually, this is all cystic duct which is dilated, retrospectively speaking. Very difficult to call it like this, but it is now. This is the communication with the gallbladder. And this is all gallbladder. So there is a stone sitting here. This is all dilated cystic duct. This is the common hepatic duct. Of course, on the CT scan, you cannot see more than this. And it is compressing it, and you don't see the stones very well. When you see enhancing walls of the biliary duct on a CT scan, call it, because that is abnormal. It can be cholangitis. In this case, it should be cholangitis, a bit of cholangitis. And in other cases, it can be a cholangiocarcinoma also can cause enhancement. So enhancement normally should not be there. This T2 haste shows you everything very well. Common, the distal CBD is normal. Now, these are stones sitting in the cystic duct, and they are causing compression. And you can see the common hepatic duct from here onwards is dilated. And then this is the neck of the gallbladder, and stones there. Okay, and then regarding the ERCP, the gas, this is what we did. We said, don't worry about it. And they followed it up. They did ask for a CT scan, which this is a follow-up CT scan, and the gas has completely resolved. And on the other hand, we then involved the surgeons to deal with the, because this was a surgical case, they had to remove it. It cannot be an ERCP case to remove the stones, I mean to say. So it was referred to the surgeons, but not for the gas in the retroperitoneum. Okay, before I continue, because I just want to announce something, that what we are thinking is to show recordings of our Basildon A to Z course 2020. And this will be a huge opportunity for